The real opportunity this morning is to view a mock comprehensive care visit with a real patient who has been treated at a hemophilia treatment center and understand those dimensions that that team goes through in talking with and working with a patient with this disease. Sue Garrity will begin the patient discussion in this visit with an overview and then discuss her role as a hemophilia treatment center nurse. Each individual on the team will then talk with Patrick Lynch, our real patient this morning, about issues surrounding his treatment, his disease progress, and concerns he has of a variety of types. And Dr. Tarantino at the end will then summarize with a few key points.
Hopefully, this will bring to light what our role at a comprehensive hemophilia treatment center is and how we can help partner with you all in order to get our patients the best care. So, comprehensive care, the model was set up in the 70s, and really when I think of comprehensive care, the patient is the center of that model, and the rest of us are kind of spokes around the wheel with the patient being in the center. So most comprehensive hemophilia treatment centers try to meet prior to seeing their patient to discuss what issues we may have or we may perceive that the patient has. So we're having our pre-comp meeting, and Patrick is a 28-year-old male with severe hemophilia. He has a history of a high responding inhibitor, which is what Dr. Tarantino was talking about. He was diagnosed at birth by cord blood because he had an uncle with hemophilia, so the family knew that having a son with hemophilia was potential. At the age of 2, he developed an inhibitor, which is very typical, again, from what you heard from Dr. Tarantino, and his peak Bethesda titer was 10. Patrick underwent immune tolerance and received daily factor VIII for 18 months before his inhibitor was tolerized. At that point, he transitioned to prophylaxis, using factor on a regular basis to prevent bleeding episodes. During this early time of his treatment, when the inhibitor wasn't under control, he had multiple bleeds into both his ankle and his knee, and that resulted in some significant changes. His immune status is he's been vaccinated for hepatitis A. He is hepatitis B core antibody positive. He's hepatitis C positive, and he's HIV negative. He works as a software engineer and has a long-term girlfriend, and he has had surgeries in the past. He had an appendectomy in 2000 without any complications and a synovectomy in 2010. So when we look at our pre-comprehensive clinic meeting, we look at what the past year has been. Most comprehensive care centers try to see their patients at least annually, and oftentimes in the pediatric population, we see patients twice a year. So when we review Patrick's history, we know he had one hospitalization. It was following a motor vehicle accident, and he hit his head on the windshield and was kept overnight in the hospital. He also had wisdom teeth extracted in this past year. He had a couple of visits to the clinic, and we looked at laboratory results during those clinic visits and talked about the breakthrough bleeding he was having. He had multiple phone calls with the nurse coordinator. The nurse coordinator often is the first person that the patient with hemophilia contacts when they're having an issue. And during those phone conversations, some were regarding prior authorization, some were regarding his past hospitalization, and then Patrick also had some questions about the new hepatitis C treatment. He came in twice to see Mark, our physical therapist, and he also met twice with Peg, our social worker, regarding issues he was having. So with that, we're going to get started. And when you look at what a nurse does on the team, as I said, we're the first person that the patient often goes to on the phones when they're calling with an issue, but we're also usually the first person that sees the patient in comprehensive care clinic. And we assess the patient's past year, what's been going on. We look at their general medical issues. We look at their factor utilization. Are they following the treatment plan that was prescribed? Are they using more factor than needed? Are they using less factor? Are they keeping infusion logs, which is a record of how they're using the factor? We do a lot of patient education. We talk about their dosing. We talk about expectations that they may have for the upcoming year. And in Patrick's case, we're going to talk a little bit about a potential synovectomy that he's interested in. We make a care plan, and we follow that care plan and make adjustments to that care plan in the upcoming year. So when the patient leaves clinic, they have an idea of what their care plan is going to be for the next year and how we're going to implement that plan. And lastly, we review all medical issues in addition to the hemophilia and hemophilia-related sequelae that the patient has, just to make sure they're following up with their primary care physician. Their primary care physician is an integral part, even though they're not in attendance at the comprehensive care visit, they're an integral part of carrying out that treatment plan throughout the upcoming year. Patrick's already in the exam room, and I'm going to come in and meet him. So hi Patrick, how are you doing?
Good, how are you, Nurse Sue?
Good, good. How's your year been?
Pretty good.
I want to know how you're doing after that motor vehicle accident.
Sure. I'm fine now. It was really scary, but I was well enough to be able to get home. When I called you it was from home, infused there, and then like you said, I brought my emergency dose with me because they were not going to have any at the hospital, and you had called the emergency room, so by the time I got there, they were already ready for me.
Great.
Just stayed one night because of the head, hitting the head. Here's my folder, by the way.
Thank you.
Because of hitting my head, they ran a CT scan. It was negative, but they wanted to just observe me. There were no headaches or anything the next day, so went home. Just had to miss one day of work.
Great.
Yeah.
I think that's really good that you recognized that you needed to go home and infuse before you went to the emergency room, because you knew already that that particular ER didn't have factor. So that was a great thinking on your part.
Thank you.
And it was really good that you sent us the logs ahead of time, because we were able to review your logs. And in looking at your logs, I remember that we had had a treatment plan for you to have your wisdom teeth out. How did that go?
That was really smooth. Took the Amicar as prescribed and just followed the regimen. And yeah, I logged every infusion from that as well. And I think I emailed those two through the app.
Yeah, that was really great. It was so nice to get logs ahead of time, because when we get the logs ahead of time, we have time as a team to review and see what your issues are.
Right. But yeah, the wisdom teeth, it was fine. Went just according to plan.
Good. And how about infusions? They're going well?
Yeah, I do it in the mornings before I go to work, Monday, Wednesday, Friday. And I have the half dose Monday and Wednesday, and then the full Friday to carry me through to the weekend. I have been having some more bleeds going on in the knee, so I did want to talk about that. And
yeah, I noticed you had 5 breakthrough bleeds into that knee this year. That's a lot for you, but they've all been more recent. They weren't early on in the year.
Right.
So can you look at, I looked at your logs, and I think most of your bleeds were taking place on the weekends. Can you identify any reason why that might be happening?
Well, I'm more active on the weekends. I do like to go on mild hikes when the weather's nicer, but I've been doing that for a pretty long time now. Since the bleeding started happening more often, I've been less active on the weekends and less active during the week, but now that's resulted in some weight gain. And I feel like that's also causing more stress on the knee. So I feel this downward spiral coming. And I know how smooth the synovectomy process was on the ankle and how much it changed my life. So I really wanted to talk about if that's something I should be thinking about for the knee. Yeah,
I think, it's something that we're going to have Mark, the physical therapist, see you, and then after he sees you, we can certainly talk with Dr. Tarantino and see if surgery is an option.
Okay.
I know a lot of guys really do feel like surgery is beneficial, but we also need to look at other things that are going on with you. So you mentioned the weight gain. I know when we talked previously this year, your weight was maintaining, so it seems like this weight gain's been more recent.
Yeah.
And we haven't adjusted your factor up. And so when I looked at the dosing you're doing, originally we were shooting for 50% correction on Monday and Wednesday and 100% correction on Friday. So getting your levels up to that more normal level would prevent this breakthrough bleeding. But when we looked at today with this recent weight gain, we see that those levels are only more like 40% on Monday and Wednesday and 80% on Friday. So I think we might need to look at increasing that dose. We'll talk to Dr. Tarantino and see what he thinks, but I'm guessing he's going to want to up your dose. So how many doses of factor do you still have at home?
I think 10.
Okay, so after we talk with Dr. Tarantino, we'll probably need to contact your home care company and have them augment those 10 doses with a smaller vial to kind of get you up to that normal level.
Okay.
And speaking of home care companies, how's that going? You're not having any trouble getting factor and all of that at home?
No, usually when I'm down to 5 doses is when I place the call. If they haven't already called me, we have the same schedule, so it's who beats who to the phone call, and then the next day I have it along with any supplies. They pick up the red bins, and
Great.
It's all been going really smoothly.
That's really good. So what our goal would be is eventually to get your dose up to where we think it should be, and then you had mentioned that you are less active because your knee bothers you, so you're not doing the activity. So if we can get your factor level up, get you feeling like the knee's not as bothersome, and then maybe your activity will improve. We can always adjust your factor dose back down.
Sure.
So if you're active and you lose that 15 pounds you put on, we can certainly decrease your factor level again. So with each month when you call to order factor, we can certainly make that adjustment. So,
Okay.
And then the other thing we want to look at today is you had mentioned surgery. And I just
Right.
want to review, if you decide to go forward with the surgical procedure, and as you probably remember with your ankle, it's a big undertaking. So we
Yeah.
want to make sure that your orthopedic surgeon is on board, that they understand your hemophilia. We also need to look at making sure that the hospital that you're going to has an appropriate amount of factor on hand, so that we can maintain your levels for surgery. And then you need to consider how long you're going to need to infuse. So instead of infusing every other day or 3 times a week following surgery, more than likely you're going to need to infuse daily for a period of time.
Right,
How are your veins holding up? Are they doing okay?
Yeah, they're doing fine. There's like 5 different veins that I rotate through, and I use different spots on even those individual veins. So I don't feel like any one of them is building up an excessive amount of scar tissue or anything.
Because if you wanted to, if you do go through with the surgery, if you want to, we can look at getting a PICC line in for the short term too. So that's
Right.
another option.
Right.
Certainly not something we have to do, but something you might want to consider.
Yeah, that's a good
And then lastly, I notice you have your medic alert.
I do. I'm a
Perfect.
good boy.
You are a good boy. That's really important. And, having that motor vehicle accident and hitting your head, that really brings it home, because if you had hit your head and you were unconscious, the EMTs would see that medic alert and they would know you have hemophilia. So that's really impressive, because a lot of times what I hear from guys your age is, I'm not wearing that goofy thing. What are girls going to think? They're embarrassed to wear it, so they
Sure.
don't want it. But that's really important. Other medical concerns or questions you have for me today?
No other concerns. I did also want to talk about, there was a new Hep C drug that I saw, that I think I called you about this. I saw
Yeah,
the commercial for it, and I know there's guys in the community who are using it. I haven't seen a liver specialist in a while.
Okay, so that would probably be the first thing. We'll ask Dr. Tarantino when you meet with him, but my guess is he's going to send you back to the hepatologist.
Sure.
Because they're really the docs who specialize in that. We don't want them treating hemophilia, and they
Totally.
probably don't want us treating your hep C.
Right,
So,
right. I got it.
So really, but Dr. Tarantino can make the referral, and
Okay.
then also we'll make a referral to an orthopedic surgeon for you if that's what you need.
Sure.
Okay?
Great.
Any other questions for me?
No, none for you, I don't think.
Okay, I'm going to go see if Mark's ready.
Okay.
And he'll go ahead and do your physical therapy evaluation, see how that knee's actually doing, if you've lost any range of motion or whatever.
All right.
Okay?
Thanks, Nurse Sue.
All right, thank you.
Before seeing Patrick, I was just going to briefly review the role of physical therapy in the Hemophilia Treatment Center. You can see on this slide, it gives you a brief overview of physical therapy and the role we play. In the comprehensive care clinic, our role is to assess musculoskeletal issues that may occur with individuals that have bleeding disorders, as well as evaluating mobility and functional status. We're concerned as far as looking at strength, flexibility, and balance as we look at injuries that might have happened to muscles or joints with bleeding episodes. Based on the patient's feedback and medical history, we'll evaluate specific joints or muscles involved in the possible bleeding episodes. Our role includes helping the patient develop exercise programs, educate them and their families on activity guidelines as well. We discuss a lot of risks and benefits of different activities, sports, recreational activities, and make some recommendations on what we believe some of the children and adults should or maybe should avoid as far as possibilities of injuries due to participation. Based on the patient's feedback, we'll also discuss some further interventions if they're required, and we'll discuss such issues as bracing, surgical interventions, and any possible rehabilitation programs related to them. One of our most important roles, though, expands beyond the clinic visit. We work on educating community providers, such as local physical therapists, school staff, personal trainers, on the importance of activity and exercise for individuals with bleeding disorders. Many schools, even some physician offices, will not recommend activity, thinking that it is more harmful than good. And studies have shown that activity, exercise, helps strengthen around joints and can help prevent bleeding disorders when combined with a regular factor regimen. So we'll act as resources and provide educational presentations as needed. Many of our patients that come to the Hemophilia Treatment Center come from several hours away. So we can't provide the direct services, but we go and train the local therapists so the patients can stay in their local communities for the services that they need. So thinking about that then, just a take-home message for the role of physical therapy. Again, assessment and treatment of the musculoskeletal issues that are related to the bleeding disorders. Educating patients and families so we can maximize their overall level of independence and active participation in things they like to do. As a member of the HTC, I collaborate with my colleagues so we can serve really the whole person and provide resources and training for community providers who have limited experience to this patient population. So at this point, I'm going to get in and see how Patrick's doing.
How are you?
All right, good to see you.
You too.
All right, so I already spoke with Sue, and she mentioned to me that your knee was really the primary area of concern you had today.
There's been just a lot more bleeding in it of late, which has made exercise more difficult, and it's kind of just become a compounded problem. So yeah, the right knee is my big concern today.
Okay, I'm sorry to hear that. We can discuss what some of your options are about your knee, and we'll do an exam to see how things compare to last year's visit.
Great.
I know I did call your local PT a couple of months ago just to review the treatment plan and just check to see if she had any questions. How'd that whole exercise program go that she helped you put together?
Yeah, it went really well. She's really well informed. She has me using ellipticals for cardio 3 times a week on my infusion days, cable machines for strength training on those same days. She's helped me review my camping and hiking activities to make sure that it's in line with what we had talked about. Okay. So that's all been going really well. The problem has been with the bleeding. I've just generally been less active and less feeling like I can be less active, and that's resulted in some weight gain, which I know is only going to complicate matters further. So that's become the problem, the bleeding primarily.
Kind of frustrating at this point, huh?
Yeah, really frustrating. And sometimes I'm sure a part of it is just on me being a little bit tentative or lazy about it, but I also know that when I push it, I tend to bleed more. So I'm trying to find that balance between pushing through getting lazy and trying to protect a damaged joint.
Okay, well, I'm sorry you're frustrated. From my role, I've got to push the issue of how important the exercise is and
of course.
Strengthening those muscles. Stronger muscles really absorb all that shock around your ankle, around your knee, and can really help prevent a number of bleeding episodes. So I want you to keep that positive focus about the exercise and your
Okay, I
activity.
will try. I'll
And
shake the negativity
boy,
out.
There you go. Moving. I'll tell the social worker to work with you that. She'll deal with that better than I do.
Okay, fair enough.
So describe for me your regular exercise program and what activities do you like to do?
So I'd mentioned the ellipticals, so I'll use those or the stationary bikes because there's no impact, so it's good on the joints. And I'll kind of switch it up just to keep it interesting for myself at the gym. The cable machines, I don't like using free weights or anything where I'm forced into positions, as we've talked about in the past. And then the camping and hiking on the weekends. And I try to walk generally during the week when I'm feeling okay, if I have the option, just to kind of get exercise in my everyday routine too.
Great. I got to say, hey, you're wearing your supportive shoes that I'm always talking about today,
Yes.
too.
Yeah, I have those, and I have the orthotics in them. I just rotate the 2 pairs of orthotics back and forth so I don't wear them down that quickly. And
Those old
they're great.
flip-flops drove me crazy, so
know,
that's
they
really good
did.
to see. How about the knee brace that the HTC was able to get for you?
Yeah, so I have the brace with me anytime I go to the gym or on the weekends when I'm out. I use it every time.
Excellent. Okay, that's good to hear that you're following through on that. And you are coordinating your exercise program with your factor regimen, correct?
Yeah, so Monday, Wednesday, and Friday.
All right, so that sounds like a great plan. Again, I'm staying out of the discussion of how much factor. We'll leave
Right.
that to you speaking with the nurse and Dr. Tarantino later. But again, if there's any consideration of that, make sure you have a clear discussion with both of them.
Of course.
All right, great. So before we get started on your physical exam, let's talk about the synovectomy.
Yeah.
I hear you're interested in that, and you understand the goals of the surgery?
Yeah, I mean, I remember it in general from when we did the one on the ankle. I know there's the different kinds, and I'm not 100% clear on that because it has been 4 years, but I'm assuming that Dr. Tarantino and I will kind of go through all that towards the end.
Right. Yeah, I'll let him discuss more of the details of what the surgery involves. I just let you know that we recommend the surgery for somebody that's having frequent bleeds,
Right.
even when following a regular regimen of factor use.
Right.
So basically now your right knee's becoming the target joint, right? So we're concerned when that continues to happen. The goal of the synovectomy is to decrease the number of bleeds by going in there and cleaning up that joint and the synovium.
Right.
By doing that, we can decrease the number of bleeds, but from a PT's perspective, the important part that goes along with that is the exercise program. Because you just can't go in and clean it up and then not do anything.
Right, right.
We see this procedure really as an opportunity for you to work on getting stronger, getting a little bit more mobile again. You'll get a little range of motion back and some decreased pain, and get you back to that activity level that you're really looking for.
Yeah, I'm really curious to know how many range of motion numbers compare to last year when we go through the exam, because I'm wondering if it's already begun to kind of decrease over the last few months. Yeah.
Some of the comments you'd made, yeah, I was thinking about that. And when Sue spoke with me, she was thinking that it seemed a little stiffer too.
Yeah.
So that's great. Again, our goal is going to be to get you back to your regular activities. We don't want you missing work.
Right.
And we think the synovectomy, along with the exercise rehab program, can really help pull things together so you can get back to your regular lifestyle.
Should be great.
Do you remember the pre- and post-surgery rehab program that you did before?
Yeah. Again, in general, I do. I would want to go through it all again. I know it was lengthy and involved, and it's been 4 years, so I would definitely want to review it again.
I think a key point that comes to me now is just from some of the comments you made is that we're really going to want you to be involved in a pre-op and a post-op rehab program. So by going for the synovectomy or any surgical procedure, you really have to agree to be committed to that program before and after.
Sure.
And be able to fit that into your schedule. So
Sure.
I want you to keep that in your mind.
No, and
because-
I realize it's a very serious consideration, and but like I was talking about earlier, at this point, I know that it's not going to get better on its own. That something needs to change. I need to maybe change my behaviors. Maybe the surgery is the best option, but whatever we decide, I'm committed to figuring it out.
Okay, that's great, because I think with the right mindset after the surgery, we can really get you moving towards increasing your mobility, your activity, get you back to work, so this isn't such a daily problem.
That would be
for you.
fantastic.
So if you don't have any other questions, we can start your physical exam at this point.
Yeah, that'd be great.
So at this point in the clinic, I obviously do a physical exam that I'm not going to do to Patrick today. So we do range of motion measurements on the different joints and muscle groups that in the past have been a problem, but then also specifically focus on the joints that he's telling me about. So he would get a full evaluation, really looking at that right knee, that right ankle, that right hip, up and down that extremity. Compare, as Patrick said, compare those range of motion and strength measurements to the last time, and also with some of the information I've gotten from his local PT. And from there, discuss, okay, these are the findings that we have, and then how are we going to move forward with this. So as my role, I would let Patrick know everything we found, discuss it, but then go back to the team and share this, and then Dr. Tarantino will come in and pull all our information together. So at this point, I'd say, Patrick, pleasure seeing you.
Good to see you.
You know, that weight gain, try to cut down on the s'mores when you're camping.
I'll do my
other
best.
stuff, but, you know, and then we'll work this out, and I'll keep trying to see how we can get you moving forward.
I appreciate it. Thank you.
Thanks. And then I think Peg's going to come in and see you now.
Great.
I'm Peg, and I'm here to talk about the role of the social worker in the hemophilia multidisciplinary team. And I am very honored to work in the field of hemophilia. We have a lot to contribute, and it's a wonderful opportunity to work in a chronic care area where actually you have the opportunity to get to know patients and families over the long term, which usually isn't in the case with most of the fields of medicine that we deal with. And if you've never dealt with social workers, let me tell you, we have a lot in common. You may not know it, but social workers are usually the budgetary people on the team. There is so much that we have to get into with finances to support the physicians in the treatment plans that they want to order, and to support the patients to make sure they have coverage. We want to maximize outcomes and minimize costs in many ways. So we have a lot in common. We work a lot with insurances, getting pre-authorizations along with the nurses. And we're not interested in maximizing costs to health plans because we want to make sure there's a future for treatment and options available over the long term for patients. So we do have a lot in common, and our focus is much the same. So just very general, to give you an idea of how a social worker functions in a hemophilia treatment center. The basic thing we do in our role is to do a good psychosocial assessment, which gives the team a basis of what's going on with a patient and a family. And psychosocial means just what it says. Psychological, which is the emotional well-being of the patient and the workings of the family. And social, which is all that's going on with them, where they're living, how they're living, if they're working, if they're disabled, if they have an income, all those kinds of things that fill in the cracks of what Dr. Tarantino and Sue are trying to do medically for the patient. And in trying to do a psychosocial assessment, they all vary because it's very different on how your approach is going to be. As you know, for a new patient, that visit is going to take much longer and need much more input. For someone that we don't know, we need to get the history and the plan together. As for someone, and that differs greatly when we have an established patient like Patrick, who we've known over many years. So many times we can pull information from the top of our head and know what's gone on with them and just kind of go from here forward. It's very different whether you deal with a pediatric patient, because think of that pyramid that you're dealing with. You not only have the baby or the little boy, I'm saying boy, they're usually little boys, and sometimes you're dealing with a whole family, the issues, the dynamics, the questions that are involved there. So you have a whole family that you're treating with a pediatric patient. With an adult like Patrick, sometimes they do bring in their significant other, so we do have patient and family things that we have to look at. With Patrick, he's alone today, so we've only got one focus here. When we do a good psychosocial assessment, we're looking at things like demographics, employment status, insurance, things that are very, very important to planning for his future, as well as the emotional issues that are going on. The reason that we start with these kind of things is it's very non-threatening. Concrete issues, very non-threatening, but you would be surprised in a treatment room what kind of things come up with very, very innocent questions. The reason that we're doing this psychosocial assessment is we're trying to identify the challenges and barrier to treatment. I mean, hemophilia treatment is our primary focus, and the patient we treat holistically all around that and try to catch anything that's going to fall into the gaps here. So if we can find out if the patient moved, did the patient have insurance, does the patient have a home, simple things that seem very logical, but I can remember a case when we had to work very closely with a specialty pharmacy because we had a homeless patient. Where were they going to deliver the factor? It was a big problem. So these are the types of challenges and barriers we want to identify so we can deal with them and work and make a successful plan with the physician. And also, along with this, what we want to do is go backwards. We probably had a plan with Patrick at his last visit 6 months or a year ago. So we want to see how that worked out. And along with that, we discuss issues that Patrick and concerns Patrick may have so we can build a cooperative plan together and work on for future success. So now I'll go in to see Patrick. Now I'm wondering how things are going and have there been any major changes in your life in the past year?
Well, other than the stuff that I'm sure they already filled you in about, I don't know if you remember from last year, we talked about I was moving with my girlfriend and
Yes.
that whole business. So this year we're going to talk about how I'm moving out because she is no longer the girlfriend. So that happened.
That's a very big change in your life.
It's a pretty substantial shift. So I'm living in a studio that's like an hour north now of where I was.
So it brings you further from the center.
Yeah, I'm significantly further actually from here. And I didn't think about this at the time because it was, I mean, I don't know, you're kind of messed up during those periods, but it's a walk-up. It's a 4-story walk-up.
I see.
Which wasn't a problem until all this knee stuff started going on, and then just like doing laundry and going down to the grocery store, and I'm ordering more food in, and it's more expensive, and so I'm not really sure what I'm going to do about that. Signed a year lease, so
Okay.
I have
And
to figure that out.
So when you say 4-story walk-up, there's no elevator.
Yeah, there's
up
no,
and
yeah.
down. And do you see that, has that already caused problems for your knee, the walking?
Yeah, when the knee is bad, or even when the arthritis is flaring up, it's just the general up and down the stairs is not appealing. So I'm avoiding things that I would be doing otherwise. And then, like I said, if it's food related or whatnot, I'm bringing things in, it's costing more money, or I'm not going out socially, I'm not going. It's actually, I was talking to Mark about not going to the gym and being a little lazy, but I think part of it is also I don't want to go up and down 8 flights of stairs, to go to the gym.
So already we have our first issue that really we need to bring to Dr. Tarantino so he knows the aftercare would involve.
Oh, of course. Yes,
all
yeah, I
the
didn't even think about
stairs.
that. Yeah, because that was not the case when I got the ankle done. Didn't really think about that. It's a good
Now,
point.
And how about the girlfriend emotionally? How long has it been since you broke up with her?
Like 2 months.
So it's still new.
Still pretty new, yeah.
And how are you doing?
I don't know.
Yeah.
Just, little by little. To be honest, I'm more concerned right now about the knee stuff because that's just a bigger day-to-day consideration right now.
So you live alone in this apartment then?
I do, yeah.
She's not there. No new roommate involved?
No, it's just a small little studio.
Okay. So, and did Mark talk to you? Would this surgery involve rehabilitation as an inpatient or an outpatient?
I feel silly, but I didn't even think to mention it to Mark. Like, we don't talk about my girlfriend, you know what I mean?
Yes.
So I just didn't even think about that part with the surgery.
Oh, I see.
Yeah, and all this.
So there's some thoughts about getting your meals and
Right.
those kind of things at home, and
Yeah,
would
it'll be
support
different.
You.
Yeah, I didn't think about any of that. I mean, she was around last time, and my mom was living closer too when the ankle was done. So I kind of took for granted that the support was there, but life is different now. I didn't really think about that.
So those are things that we can expand on more with Sue and Dr. Tarantino about how we would work on those circumstances, those situations at home, so we could make it successful for you.
Okay.
So I think we'll talk to the medical team about that. And I think in preparation for your surgery, are there any other concerns that you have, say about work or vacation time or disability?
I get kind of confused with that stuff and with the HR at work and like how much time off I'm going to need. So I'm not precisely sure what the best next step to take is in terms of planning for how much time I'm going to miss. I can do some work remotely because it's computer stuff.
Oh, great.
So but I haven't begun that. I wanted to have this conversation first before I started talking to my job about it.
Oh, that's a good idea. That's a good thought. Because once you let it out, it's out there. So it's good to be as prepared as you can be.
Yeah, and they're already pretty confused with my medical needs. So.
Right, right. And there might be a concern and an issue that we may need to talk with your insurance, so make sure if there's any co-pays or deductibles that you need to be concerned about, and if there are large balances that you're unable to pay, perhaps we can network and find the resources. Most of the pharmaceutical companies do have resources and plans where you can apply for additional monies to help you with those.
That actually reminds me, I want to talk to you too. I forgot to bring them with me, but I have some bills regarding the accident, the car accident, and I'm not quite clear on what they're about. And I tried making a phone call, but it wasn't really a productive conversation. So if we could maybe review those together, if I could send them to you and we can talk about it.
Oh, that would be great. Now, as you know, the insurances won't talk to me anymore.
Right.
Years ago, we used to be able to do that, but now we either need your release or they really prefer to talk with you. However, if we're both looking at the bill, maybe we could go through and make a list of questions and concerns
That'd be great.
so you can make your call as productive as possible.
Yes, that would be wonderful.
All right. I think we have a good short-term plan in place then, Patrick.
Good, well, thank you.
And we'll make a plan of phone calls so we can keep in touch, see how you're doing
Okay.
in your living situation and doing toward the progress of this upcoming surgery.
Well, thank you, Peg. Appreciate it. Good to
Nice
see you.
to see you, Patrick.
You too.
Before I tell you the hematologist perspective, this is sort of a core example of the comprehensive care team. Many comprehensive care teams around the country also incorporate nutritionists that help patients deal with issues, even ones that, like Patrick is mentioning, helping people to get to their ideal body weight, and obviously that can affect treatment and dosing, et cetera. We typically have genetic counselors that either staff with the clinic or serve as liaisons. There are a few clinics around still that have orthopedic surgeons that actually do come to the clinics, but most often physical therapists like Mark are on the staff at the comprehensive care clinic. Okay, so the hematologist's job is really to sort of assimilate all the information that the nurse, social worker, physical therapist, dietitian, dentist bring together and see how it affects some of the medical outcomes that we could potentially prevent or improve. So typically we don't just rehash everything that's been done already, but the factor dosing issue, if it is leading to a medical issue, then we typically address it and then work with the person with hemophilia to arrive at modifications that might improve and prevent bleeding better. And then typically, even though I'm not a hepatologist, I'm not an orthopedic surgeon, we serve as sort of the coordinating team to help get the patient to those appropriate people to help make the decision of, say, is it appropriate to start hepatitis therapy, or is it appropriate to have a synovectomy for a joint-related issue? So we work very closely with all these liaisons we set up, and actually over time, those liaisons, like Mark alluded to, these are people that we work with repeatedly over time, so they're essentially part of the team. They have experience with hemophilia. In rural centers, like the center we have in Peoria, sometimes we're forced to work with practitioners that are in those local areas for the patient that have no experience with hemophilia at all. Some of them actually have no desire to work with hemophilia. We are always, happy to bring the patient into our town to have a procedure done, like an extraction of a tooth or some minor surgical procedure. But we know that influences the person's overall health. So we really make this a comprehensive approach to even the whereabouts or where a procedure is going to be done. Okay, so I'm going to talk with Patrick and sort of wrap up some of these ideas and try to formulate some kind of plan. So talking with everyone, I understand you've got a change in status on Facebook.
Yes. Wow, word travels quickly. Yes, I am a single individual.
Yeah, so how's it going with that?
It's going okay. I mean,
Yeah.
Peg and I talked about it a little bit. It is what it is. As I was saying to her, though, my bigger concern right now, and maybe this is why we broke up, is that the knee is the thing that I'm thinking about more. It's kind of concerning me.
So you moved to a new place, I heard.
Yeah.
Right, and you're walking up steps, is that right?
Yeah, it's a 4-story walk-up, which I didn't think about when I was talking about the synovectomy earlier, and I'm sure you guys were talking about that, but obviously that's a different situation than I was in the last time I underwent this kind of procedure.
Right, and I don't want to remind you of it, but I heard that you gained a little bit of weight, and maybe that you're a little less active because of that.
Yeah, well, it kind of became a spiral because the knee there was more bleeding episodes, so I was less active, put on more weight, which I'm sure compounded the bleeding episodes. Nurse Sue reminded me earlier that my factor dosing is probably now inadequate because of the weight gain. I didn't do anything about that, so.
Yeah. So tell me about that knee, the knee that's given you the most trouble. Have you had many bleeds in that knee before this most recent sort of episode of bleeding?
It's been a target joint, as we know, but the bleeds had really been reduced since I switched to the prophylactic regimen, and even with all the exercise, I'd built up the muscle strength and whatnot, and just in the last 6-7 months, I've noticed this change.
Gotcha. Okay, so we're on the same page about that. When we say target joint, that either means you've had more than 20 bleeds in that joint in a lifetime, or you've had more than 4 bleeds in that joint in the last 6 months. So do you think you meet that criteria?
Yeah.
Yeah, okay. So, all right. So I know you had questions about maybe doing something about that surgically.
Well,
what are you thinking?
Well, to be honest, when I came in, I really wanted to leave with everybody kind of agreeing that the synovectomy made a lot of sense. But as we were talking about different considerations, I'm realizing that is maybe not the best option right now. I don't want to take it off the table entirely, but if we could maybe look at adjusting the factor and seeing if that helps me become more active, and then if I can build up the muscle strength and see if there's a different behavior pattern that I can change to help this heal.
All right, Patrick, you took the words right out of my mouth. It's great when members of the team do my work for me. Yeah. So yeah, I think that would be a great idea, and it's probably worth a trial period of better, maybe a little more intensive therapy for that ankle, and maybe we can avert the synovectomy, because as Peg and Sue and Mark probably talked to you about, there's a lot involved. As you probably remember from your ankle, there's a lot involved leading up to the synovectomy and then the rehab period. Are you living on your own now?
Yeah.
And would you have support to help you with things after the surgery?
That's the other thing I didn't think about. I mean, I took for granted that it was just there last time. So when I was thinking about it, it's like, oh yeah, that was there last time. But I'm not sure what I would actually do about that.
Yeah. Okay. So let's in the background maybe start thinking about how we would manage that. But in the meantime, let's give a little trial period of more intensive factor therapy, a dose adjustment, and then we'll touch base and we can see how that goes.
Okay, that'd be great.
Yeah. So what other issues are going on?
The only other major thing, I'm assuming that you guys talked about the motor vehicle accident and everything from that is where it needs to be. It was scary, but.
Yeah, tell me one thing about that. What was the circumstance? Was it just out of the blue, or was there something going on? Were you stressed out and not paying attention, or what?
I was in the right lane, they were in the center lane, and they were in the left, and we both were trying to get to the center at the same time and didn't see each other. So just kind of one of those freak weird things.
I just wanted to make sure, just to be frank, I just wanted to make sure it wasn't related to
Me
issues
being an
with
angry driver?
or with your, with your breakup and maybe some issues that might have been happening before that.
Okay, that's fair. No,
Yeah.
it was just a weird circumstance, just a
Okay.
freak thing.
Sounds good.
But the only other like real action point that I want to address is the Hep C drug that I've been hearing about. I realize that that's not a thing that we would necessarily be doing, but if you could connect me to a liver specialist that could kind of have a conversation with me about that.
Yeah, absolutely. You've probably heard, or maybe even via TV commercials,
Yep.
that the landscape may be changing right as we speak even, about how Hep C is going to be managed. I don't think things have been fully sort of worked out, but I know that there's some new therapies causing excitement. So yeah, I think the best thing to do is we'll get you in to see your hepatologist very soon. You guys can talk about that, and if there is a plan to move forward, then we'll certainly be involved as well. Sometimes we need to document, your stage of liver disease, if you have any from your hepatitis. Sometimes that drives whether therapy gets started or not. If it involves a biopsy, for example, you would obviously need some factor before and after that.
Of course, yeah.
But I think the most important thing is, this is a timely issue, and we should get you in to see your hepatologist right
That'd be
away.
great. That'd be great.
I'd now like to ask Dr. Panolia to come up and share with us a payer perspective in terms of comprehensive hemophilia treatment, particularly new models of care.
One aspect I know as pharmacists in the audience, you're probably going, wow, this is a huge multidisciplinary team. You saw a social worker, you saw a nurse, you saw a physical therapist, saw a physician, and you're like, where was the pharmacist? So much of this is driven by factor. And I just want to let you know that the hemophiliac treatment centers that are federally designated have their ability to get 340B pricing on drugs is there because of that designation, and they work very closely with their specialty pharmacy. And so the specialty pharmacy staff is not part of the comprehensive visit directly for face-to-face engagement, but they work very closely because they're usually on site, and they work very closely with them of aligning, like when the nurse said that we're going to see how much dose you have in stock, and now we're going to just supplement. Instead of just giving 10 new vials of the new dose, we're just going to give you maybe 2 smaller doses to make up and make that full dose, as an example. So they are an integral part of this. I just wanted to make sure everyone felt comfortable with that. We talked about the stats. Just so you understand, if you look at the mean healthcare expenditure per hemophilia patient in the commercial, without inhibitors, it's $155,000 per year. With inhibitors, it's almost $700,000 per year. So those are our $1 million cases that we see. So again, looking a little bit more at prevalence, again, it's very small prevalence-wise. For commercial, it's 11 out of every 100,000 that have the hemophilia A and about 2 for B. Medicaid, that doubles. But if you look at the cost, the hemophilia cost, if you look at just the hemophilia factor, that's what's driving it up. It's 75 to 85% versus your hospital, professional, and drugs. C is for commercial, M is for Medicaid. So you can see overall, it's this portion that we really are trying to address if we were trying to decrease the cost as well. The challenges of hemophilia that we know in managed care are trying to get treatment access to highly qualified individuals that specialize in hemophilia, having appropriate multidisciplinary teams, having cost and pharmacy management to go with that. They're all parts of things that we know we're facing. If you look at how we're going to try to manage and control this total cost, we know if we can get the proper dosing and get the patient to adhere to this, we're going to see a reduced number of bleeds, which decreases the number of infusions, decreases ER and hospitalizations, and leads to improvement of quality of life. But it all stems from having the appropriate dose and making sure the patient's adherent to it. So who are the people that are helping with this specialty? With the drug management, we have specialty pharmacies, and I'm just going to let you know, this could be as managed care institutions that we have our contracted specialty pharmacy providers, or it could be the hemophilic treatment centers and them using their specialty pharmacy providers. And I think that's something that, that there's an opportunity for us to learn a little bit more, that we're not duplicating efforts there. Looking at drug dosing, we've already heard from Dr. Tarantino about the data that shows by doing prophylaxis we can get long-term savings. And then If you look at the starting dose, it's a wide range, right? 30 to 50 units per kilo, depending on which hemophiliac, if you have hemophiliac A or B, and if you're doing prophy versus on-demand dosing, it's a variance, but there still is a range. And when I was looking at our data, even if we can decrease, let's say, an average of 45 units per kilo to 35 units per kilo, for every 10 patients, that's about $200,000 savings. So if you just look at, is that acceptable? WHO guidelines have it even out down to 20 to 30 units. It's not something as a managed care institution we can do independently, but I think by working closely with the HTCs and starting to understand what are those opportunities, that there is something that we can do on decreasing that in a safe manner. The opportunities for existing for health plans to improve our outcomes is really through the collaboration. So I'm going to just kind of stay here on this slide and do the remainder of the discussions probably, but if you look at it, we have an opportunity to do improved collaboration with the physicians that are providing the care. Their whole goal is to help improve the well-being and the care. Hemophilic treatment centers is another opportunity. So we have about 30% of hemophilia population that go outside of HTCs. So that's where the physicians, and it could also be the hepatologists and others that are involved in the care. But the hemophilic treatment centers, where we just saw this whole comprehensive visit, there's this whole multidisciplinary team that's giving the whole full support all the way through, and then looking at integrating our specialty pharmacy, there is a way to increase this collaborate. If we were to collaborate more, we could increase the opportunities to determine if there's a better way to manage these patients together, I guess, versus the way we're kind of doing in silos in many cases. The utilization and sharing of the data, I think, is the key part. So I'm learning a lot as I'm trying to figure out how we're going to try at Health Alliance Plan to improve our management process for hemophilia, that the hemophilic treatment centers have an abundant amount of data that we don't even tap into, because as a federally designated institution, they have to gather all this, not just demographic, but things that we would consider as our outcome metrics for appropriate drug dosing, make sure there's no utilization, make sure there's not overstockage. We have our pharmacy that will call and make sure it's time for the next delivery. Well, they go a step further and have a social worker and a nurse and everyone else involved, and oh, your weight changed by 10 pounds, so guess what? We're going to decrease or increase your dose. I don't think at a separate entity that we do that as well as this group, that's what they're tailored to work on. So if there could be a better collaboration of our data to understand where do they bring more quality, where can we do more collaboration, we can probably really improve the quality of care and decrease the cost better. Also, you noticed in the visit there were multiple telephonic visits that were needed to really make sure before you get to the next annual comprehensive visit, this patient was well taken care of. And I know we have heart failure, especially in looking at how do we pay payments for telemedicine. Well, here's another area that might be an opportunity to look at, if we can make sure that this truly is reducing the cost, reducing ER, and making appropriate decisions on dosing. That's an opportunity there as well. So, we saw this already through what a comprehensive care visit does, and, they proactively will call, they implement steps to avoid the ERs, make sure there's no shipments when there's already stuff on hand, information gathering. We have bleeding log history, but they also have drug log histories. I mean, they actually have exactly the dose that was used on the day and the time, and they can know right away if this patient's adherent or not, and we know that has a huge impact on the bleed rates, which then lead to the surgeries, which then lead to higher doses, and so you can see how that really starts adding up. So the points of contact and interactions between the hemophilic treatment centers and the specialty pharmacies, if they're independent and they're outside of hemophilic treatment centers, I think that's another opportunity we really need to look at as a payer group. If we're going to continue having the factor supplied by our specialty pharmacy, is there as much direct communication, and make sure that we really are watching each dose that it's being given. So, we saw this in the previous slide about this. Just so everyone understands, there's 8 regions for the regional hemophilic treatment centers that are being designated federally. And on the east side, you see it's pretty heavily loaded with the number of HTCs, right? Great Lakes which is where I'm from, so you have 21 right in that area. But then you go to mountain states, and for the 11 states, there's 11 HTCs. So, a great need to understand how do they interact with patients across their whole state? What are their opportunities if they, especially if you have a severe hemophilia, possibly with inhibitors, they need that close monitoring that would probably be better done through an HTC, and how would we collaborate with that? So in summary, the collaborative team, this has, I think, been thoroughly discussed of who's involved in there. And so looking at what are the values of having a hemophilia care administered through an HTC versus non-HTC, the implications for us is definitely we see a definitely much more comprehensive visit. There could be a nurse, there could be a social worker, there could be a nurse, there could be a hepatologist, but if they're all done independently, and especially if the surgery is being done by a surgeon who's not very familiar with the whole disease state and what's needed on hand, they can have some terrible outcomes. Benefits include the continuity of care, access to the specialists and treatments as needed 24/7, not only 6 weeks out when there's availability, et cetera.